If I haven't had the chance to introduce myself to you yet, my name is Sarah Irwin. I have been a member of the CAPS board now for a little over 2 years. I am the executive director of the Enclave at Round Rock, which is independent and assisted living. And today I have the pleasure of introducing Dr. Kochanski, who is going to be presenting for us today. Dr. Kochanski is a neurosurgeon at Methodist Physicians Neurology Specialist in San Antonio. He is the director of Stereotactic Functional and Epilepsy Neurosurgery. He provides surgery for a broad range of brain and spine condition and specializes in deep brain stimulation for Parkinson's disease, dystonia, and essential tremor. And so I'm going to pass it over to him, and we are going to hold our questions until the end. So we'll let him go through his presentation. And then if you have any questions, I'll either read the chat box or we can have more of an open discussion once he's done with his presentation. Dr. Kochanski, I turn it over to you.
Great. Thank you, Sarah, for the kind introduction. And thank you for the opportunity to speak to all of you, and hopefully someday we can have an in-person meeting. I can meet you all in person. It's always much better to have a crowd in front of you that you can engage with. But for now, this will have to suffice. And I'm going to be talking about a topic that I'm, very passionate about and have had extensive training in. And the kind of technique which is very unique, the technique that I use to perform this surgery. So deep brain stimulation for Parkinson's disease is something that we could talk hours for, but I only have a small amount of time today. So I'm going to talk about, my specific technique for how I do the surgery. So I'm going to talk about 3 different companies in this presentation. I have no biases towards any, no financial support from any of them, and that's that. So what we'll talk about, so I'm going to first kind of talk about what is deep brain stimulation, what does it consist of, what are the components, and then I'll talk a little bit about the way that deep brain stimulation has been done historically, and it's actually the technique that I was initially trained on. And then I'm going to talk about the newer technique of doing it asleep or under general anesthesia. And then we'll kind of compare the two, look at some literature, and then we'll open it up for questions at the end. So what always amazes me when I talk to folks about deep brain stimulation is how, despite the fact that it's been around for a while, a lot of folks don't know much about it or really understand it. And so here, the timeline from a textbook that I've put here and highlighted in red some of the salient landmarks, historical landmarks in deep brain stimulation. So if you look, the first implant, chronic implant for Parkinson's disease was all the way back in 1972. And then in the late 80s, it was a different target. The thalamus was used to treat specifically tremor and the tremor aspect of Parkinson's disease. And then in 1994, they looked at the STN, or the subthalamic nucleus target. And then in the early 2000s is when it garnered FDA approval for Parkinson's disease, and is now being used to treat a lot of other disorders. So just to highlight, it's been FDA approved for tremor since '97, Parkinson's since 2002, and now there's some other indications like dystonia and obsessive compulsive disorder that are under humanitarian device exemption. So what is deep brain stimulation? Well, it consists of, this is sort of your standard system. And so the system consists of wires or electrodes that go into the brain. And these are directed towards a specific target. In Parkinson's disease, that's typically either the STN or subthalamic nucleus, or the globus pallidus, the GPI. And these leads are, obviously need to be very accurately placed within these targets. These targets are located deep within the brain, and they're very small. So millimeters in terms of error matter significantly. as these structures are located toward near other areas that you don't want to stimulate. So these wires need to be guided into the brain with the utmost accuracy and precision. And then these wires are then subsequently connected to extension cables, which run down the neck, as you can see here, and down to a battery that's placed just overlying the chest muscle. This device can be programmed using a programmer externally, either by the clinician or the patient. And the patient can be given their own programmer with the ability to adjust whatever settings the clinician allows. So one of the things that makes this field so exciting for me is the technology has progressed significantly over the past 10 years. When I first started my training, we were really only looking at one system by one company, and that was Medtronic. And this is how it looked. The wires that go into the brain looked like this on your left. And each one of those metal contacts is capable of producing an electrical current that runs through it, which then stimulates the desired structure. And so in the middle here, you see what the emitted electrical charge field looks like when a lead is turned on. And then on the right is the entire system, battery, extension wires, and leads. Well, not long ago, about 6 years or so, the first company, Abbott, came out with what's called a directional lead. And what this lead was capable of was emitting a charge in a certain direction, or it was capable of what we call steering current in certain directions. And the way it can do that is by, if you look at the diagram on the right, the middle two contacts of the 4-contact lead have separate radially oriented contacts, and you can selectively turn one or two or all three on, but turning either one or two on will allow the current to move in a direction. So you get what looks like, an asymmetric field where the current is predominantly being directed in a certain area, in a direction. Why is this important? Well, as I mentioned, we're talking about millimeters here, and we're talking about close proximity to vital structures that you don't want to stimulate. So this schematic on the right is a cross-section diagram of a deep brain structure, specifically the subthalamic nucleus, or STN. And you can see the lead is in gray, and it's located in the sort of the lateral aspect of the subthalamic nucleus. And the blue outlines what your standard lead would emit, and the red shows what the directional lead is capable of doing. Why is this important in this particular situation? Well, the area CI, just north of that blue current, that is the corticospinal tract, which controls movement and also controls speech and things like that. So you don't, if that happens, patients oftentimes will complain of what we call dysarthria, or difficulty getting the words out, sometimes pulling of the face or the arm. And so with these directional leads, they allow for probably more tolerance to a lead that's not perfectly placed. It gives more options for the programming clinician to provide a beneficial result to the patient. So now, we started with one manufacturer, and now we're at 3. And so, discussing the major differences between each of these systems get talk in and of itself. And so we won't go into it, but each system at this point has its sort of draws to it or benefits. And, we typically will implant these on a patient by patient basis, depending on what the patient may desire. And so right now, Abbott, they have a remote programming, which is kind of a programming that can be done over long distances, over something like a Zoom call, which sets it apart from the other two. Boston Scientific has a very nice rechargeable battery, which can last up to 15 years, which is nice because standard batteries can last, 2, 3, 4, 5 years, depending on how much a patient is using it or their settings. So they come in less frequently than to get the battery changed, which is nice. And then Medtronic has what we call brain sensing ability, which involves recording the brain activity and then deciding how to stimulate depending on the interpretation of that brain activity. All three have the directional lead now, so they're kind of all on the same playing field in that regard. But those are the major differences of these systems where we stand right now. And obviously that's going to change over time as each one comes out with their newer systems, and they're all competing to try to, provide the best features for the patient. So competition in this situation is a very good thing. So now let's switch gears, talk about how DBS surgery is performed. So there's the classical method where we do it awake, and then there's the contemporary method where we do it under general anesthesia. And this diagram this picture I like to have up because it really illustrates the idea that awake surgery has been around for a very long time. And so it's a tried and true way of doing surgery. It's not quite like this now in this diagram. It's a little more refined, I should say, but we've been doing it for a long time. And what is the biggest difference between these techniques? And I'm going to go into the awake technique and the way that I learned how to do it, and then the asleep technique. Well, in my opinion, the biggest difference is the patient experience. And so with an awake surgery, the patient needs to be participative in the surgery. And that's why we have them awake. The reason why we have them participative is because we turn the lead on when it's in the brain, and we ask the patient if they're having any side effects. We look for improvement in symptoms. We also oftentimes will do recordings of brain activity before we put the lead in. And so it's important for a patient to be awake so that the recordings are the most active. Patients also need to be off of any Parkinson's medications that they normally take, because we want to listen to their brain activity when it's functioning at its worst in terms of Parkinson's symptoms. So patients need to be off medication. They need to be awake. Oftentimes they're in a head frame, which you can see here in this bottom corner. And that head frame is used to provide, to allow for the recordings to be done accurately and for the brain lead to be placed accurately. Well, the asleep technique is very nice for the patient because, and I'll go into this too, but it's really not so important. The patients, even as a patient, you really see this because you don't need to participate. You go to sleep, you go under general anesthesia, and then the surgeon worries about the rest. And so in the bottom right corner, the top corner is an anesthesia machine. So you're put to sleep, and then the bottom corner, you can see the patient has a breathing tube in, and they're already asleep when the local anesthetic is being injected into the scalp. So talking a little bit about the awake technique, as I mentioned, typically we use the assessment and interpretation of brain activity in what's called microelectrode recording to decide the appropriate location to place the lead. And this requires patients to be awake. They need to participate. They need to be off their medication, and we use special recording equipment to do this. So here's just some diagrams, and this patient, you can see on the left, he does not have a breathing tube in. He's awake. He's in a head frame, and a special drape is then placed. You can see in the bottom right corner that allows for a sterile field up at the head, while everything on the other side of the drape is not sterile. And then the recording equipment computer you can see on the upper right. So a lot of moving parts to these surgeries, and a lot of a lot of components. Patient needs to be awake, need the special equipment to record, and need the head frame typically. What about asleep deep brain stimulation? Well, so this is a newer technique that's been described only more recently. And so this is, like I said, doing the surgery under general anesthesia and not using brain recordings. Well, why can we get away without using brain recordings? Well, the brain recordings are used so that we, as the surgeon, know that we've recorded good brain activity that shows we're in the proper location, so that we can put the lead in that location so that the patient then has a good clinical response. We also check when we turn the lead on to make sure that the patient's not having side effects. Well, how can we get away without doing that? Well, we have special technology, particularly at Methodist. We use a intraoperative MRI scanner. So you can see on the bottom right here, this is a picture of the MRI scanner kind of coming over to the operating room table. And what this allows for is it allows us to look at the brain during the surgery itself. And so we can tell, as long as we know where the lead is going with certainty based on the MRI, that it's located in the area that we need it to go into, then we don't need recordings. We don't need the patient to be awake for them to have a good outcome. So this is a little bit, this just kind of shows a little bit of the workflow of the technique. And as I mentioned, the patients are asleep at this point, so it's probably less important to them. But here you can just see a mock skull here on the special head fixation. And so patient is put to sleep, then put into the head fixation, and a special mount goes over the skull to point in the direction where the lead is supposed to go. In order to first decide where on the skull we're going to make a decision, we put these special grids on the head with the drape, and then we do an MRI scan. We do an MRI scan there and then, and we give contrast, and that allows for us to see the blood vessels. That MRI then shows us the grid. You can see on this MRI scan, the bright little dots on the surface of the scalp is the grid. And we pick our entry point based upon an area that doesn't have blood vessels. We do this because maneuvering around blood vessels is going to decrease the chances of having one of the most concerning complications of this surgery, and that is hemorrhage or bleeding. And so, as you can see here, we are navigating with our trajectory away from any blood vessels. This is an MRI that was just obtained minutes before on the operating room table. And so we can then pick an angle to target wherever we're trying to target deep in the brain. We then place a special targeting apparatus on the skull. So this anchors onto the bone. Again, patient is asleep during all of this. And there's a special tower that goes over it that then aims it in the direction that it needs to be aimed. We're also able to very well visualize, and this is why we can do the surgery asleep, as I mentioned before, we can see the targets very well on MRI for Parkinson's disease. So on the left here, we're looking at the subthalamic nucleus. And so it's this dark area here, this sliver. And it may not look like much here, but this is a great image, and it shows us everything that the surgeon needs to see in order to pick the point where the lead should go. And so this was a case that we did several weeks ago. And you can see I've chosen my target, and this is the trajectory that it'll be going in. If we're targeting another structure, like called the globus pallidus, we target it in a similar fashion. So this is a great image where we can see the globus pallidus extremely well. And we can even see the subdividing line between the external globus pallidus and the internal. And so we know, if we can see all of this, we know that certain areas, the posterior portion of the globus pallidus, is the sweet spot in terms of where the lead needs to go to give the patient the best outcome. And so what I like most about this procedure is that after we place the lead in the brain, we do another MRI. So we know exactly where we're at, and we can compare it to our target, or to our initial plan. And in a perfect world, and actually in this case, you don't want to see any difference between the trajectory and where your lead ended up. And you can see here, the red is the trajectory that we wanted, and the dark with the blue around it is where we ended up. And the software calculates the difference between the two. And in this case, there was no difference. We had 0 error to our target, which is exactly what we want. We were able to get this into the subthalamic nucleus, the dorsolateral portion, which we know is going to give a patient the best response to stimulation. And we were able to do it as accurately as we possibly could. There's some other software that we can use too that can look back at the brain leads and where they're located, and it can reconstruct 3-dimensionally the structure that we were trying to target and the brain lead as well. And so here you can see we're looking at a structure, the subthalamic nucleus in green, and we can see that our leads are within the structure. And this is not a very large structure. So this highlights the accuracy of the procedure. The software can then recreate, this is a 3-dimensional reconstruction just showing 2 different structures on the left and the right. The red round area is what we call the red nucleus, and then the green is the subthalamic nucleus. So we wanted to be in the subthalamic nucleus, and we are. But not only that, the software can also show us, as I mentioned, this is a directional lead, and so the software can also show us which contacts of the directional lead are aiming in which are in whatever direction. And so this is very helpful for whoever is going to turn the device on and program it, because it allows them to know exactly where that lead is located, and not only that, how that lead is turned so that they can program it appropriately. So in this specific case, one might not want to turn on E6 because we know laterally is the corticospinal tract, like I mentioned before, and so that could cause unwanted side effects. So now we know here that E7 and E5 are probably going to be the ones we look at first. So this is just a review paper that was published in 2017 that takes a look at the different types of targeting apparatuses that are used in deep brain stimulation, and then the accuracy of those systems. And so you can see the clear point system, which is what we use at Methodist, is highlighted in red. And this is about as accurate as it gets. So depending on the study that you look at, you're looking at errors or discrepancies between plan and where you end up that are typically less than 1 millimeter, which is excellent. And then what about outcomes? So they looked at outcomes of a sleep DBS, and they found similar outcomes to that of awake surgery, and these are all highlighted here. Well, another paper that was published in 2017, a meta-analysis, which basically compares outcomes of awake DBS surgery and a sleep DBS surgery. It gathers all the literature and it attempts to compare the outcomes. And so they looked at 145 total studies. Only 16 involved a sleep DBS. So you kind of have to take this comparison with a grain of salt, because there's a lot more literature out there for the awake technique because it's been around longer as opposed to a sleep. But what did they find? They found that there was, these I think are very important, significant differences in things like chance of infection or chance of bleeding with putting the lead in. And they found very similar outcomes in terms of symptom improvement. So the goal of this is to obviously make sure that we're producing outcomes that are similar to the awake surgery, but also that we're doing it safely. We know that we're doing it for patient convenience because it's much easier for a patient to just go under general anesthesia than participate. But we want to make sure that it's safe. And so this certainly highlights that. And this was interesting that came out of University of California, San Francisco, where I did my fellowship. And this is a large volume center that does a lot of awake and asleep deep brain stimulation, and really is the pioneer center for the ClearPoint technique that I use now. And so they looked at, at a center where they feel they can do the surgery very well either way. Well, what are the factors that might make them consider doing it asleep versus awake? And so they looked at patient questionnaires, and the major things that deterred patients away from the awake technique and more towards asleep were things like claustrophobia, discomfort during the awake procedure because of pain, severe symptoms when they're off medication. So some folks, said, look, there's no way that I can hold my medication in the morning and be off of it for more than 6 hours or so. And then just a non-specific fear about having awake surgery. So, having the awareness of this, allows, I think, for the best patient experience. And then just a little bit about future directions. So what do we do in instances where, as I mentioned, if we can see a structure on an MRI scan in the brain, we can get it there. We can get whatever we're trying to get there, whether it's a deep brain stimulation lead or a biopsy needle, we can get it there with good accuracy using ClearPoint. But what if it's a structure that we can't directly visualize on standard MRI? Well, there's new technology that's out, and studies that have shown that it can be done safely as well. Well, how do they do that? Well, this is an instance of targeting the thalamus, specifically the VIM thalamus, or the area of the thalamus responsible for tremor. And typically this is an area that you cannot see on MRI. We can see the entire thalamus on MRI, but we can't see the subdivisions of the thalamus. So what can we do? Well, this was a paper out of UCSF by Dr. Doris Wong's lab that looked at using tractography, or looking at what we call the white matter connections that connect areas of the brain. So these are basically the wires in a network. If we think about the brain as nodes and as a network, it's comprised of nodes, or these nuclei that we try to target, and wires, which is the white matter that connects them. So tractography allows an area of white matter that is important in something like tremor or Parkinson's disease, or even things like depression or chronic pain. It allows us to now map out these pathways so that we can then try to target the white matter, instead of trying to target a node in the network that we can't directly visualize on MRI. So here we can see that there's a special network or white matter track called the dentatorubro-thalamic tract that is it has a strong implications in things like tremor. And we can try to direct our deep brain stimulation lead towards the white matter fiber that we can now see, because we've used this technology called tractography to visualize it. So this gives us more options for doing surgery asleep in instances where historically we haven't been able to, because we can't see the target on MRI. So with that, I'll end it. And I really appreciate this opportunity and the ability to talk to all of you. This is if anyone is at all interested in setting up an appointment with me, whether or not you may be a candidate just to discuss deep brain stimulation, please feel free to contact my office. The number is listed below, or shoot me an email as well. I'm happy to talk to anyone and sit down and discuss options in clinic. So thank you very much, and I'll take some questions if anyone has any.
Thank you. Yes, does anyone have any questions for Dr. Kochanski while we have him?
Yes, Dr. Kochanski. What would cause a Parkinson's patient not to be eligible for deep brain surgery?
That's a good question. So, so first of all, typically, and I'm sure some of you can attest to this, Carbidopa-levodopa is a very effective medication for the initial symptoms of Parkinson's disease, right? It's very efficacious for the motor symptoms of Parkinson's disease. But what tends to happen over time is that patients, either don't respond to it as well anymore, or it's harder to dose because they have fluctuations throughout the day. These are instances where deep brain stimulation is very effective. Okay, so this is an instance where it's very effective. And it's effective at controlling the fluctuations, what we call motor fluctuations. So the motor symptoms of Parkinson's disease: tremor, rigidity, stiffness, and bradykinesia, slowness. What it's not effective at controlling are things like what we call cortical bulbar symptoms. So saliva, sleep disturbances, constipation, those things, those non-motor symptoms.
Mhm.
So if a patient has predominantly those symptoms, or what we call hypophonia, the quiet voice, micrographia, sometimes that's when your handwriting, small handwriting, less responsive to stimulation. So it's really, if those are the bigger or the most bothersome aspects of the disease, then deep brain stimulation isn't going to be as effective for that. Other instances where we typically don't implant are, and this is why it's important, I have all my patients get a neuropsychiatric evaluation before we consider surgery. And why do we do this? Well, we know that in folks that have dementia, deep brain stimulation for Parkinson's disease is not effective. We also know that in certain instances where there might be some degree of cognitive dysfunction, one target over another might be less efficacious. So even if there is just mild cognitive dysfunction, it doesn't preclude one from getting the surgery. It just tells the surgeon and the neurologist we should go for a different one target versus the other. So, and the other thing to keep in mind about this therapy is that it's a palliative treatment, meaning that stimulating the brain doesn't cure the disease. What it does is it makes the symptoms, the motor symptoms of the disease, more tolerable, but the disease over time will progress. There's newer technology therapies out there that are being looked at, and this is more on the research end right now, but there's promise. Things like gene therapy, or what we call neurotrophic factor injections into these areas of the brain. Those are geared towards helping restore dopamine function to the brain.
Mhm.
If those therapies work, and that's the avenue that will eventually lead to cure for this disease. But we're somewhat far away from that, I think. And so for now, we've got stimulation. And stimulation is still very effective at treating symptoms. And stimulation is getting better. The technology, as I mentioned, has improved substantially over the past 10 years. It's really amazing. That's one of the aspects of this field that I truly love, is just seeing what we had 10 years ago versus what we have now, and how much beneficial it is to patients is truly amazing. So what the next 10 years will hold in terms of deep brain stimulation, I mean, the sky is the limit, I think. So we continue to get, the technology just continues to get better and better on the stimulation side. And then these other therapies, like I mentioned, that have a lot of promise too. So I think the future is very bright.
That's great. Great. Well, Doctor, I want to thank you for putting on this program. It's helps make more knowledgeable on fighting the disease.
My pleasure. And as I mentioned, I mean, this is a passion of mine and something that I love very much. So like I said, if any of you all want to see me in my office or just shoot me an email with a question, please feel free.
What's the duration of the typical operation for awake versus asleep?
That's a good question and somewhat difficult to answer, because one of the things that's very interesting about the way this surgery is done is that if you were to, say, seek 10 different opinions from 10 different surgeons about how they do this surgery, they're all going to do it a little bit differently. Everyone's technique has some subtle differences between them, even if we're looking only at awake or only at asleep. And so a typical awake surgery that I could do would probably be about 4 hours or so, I'd say. If I were doing awake still, I don't do awake anymore. Asleep, probably about 3 to 3.5 hours or so to do it. One of the things too to keep in mind when surgeons implant these systems, some surgeons will do the brain leads only during the first operation, and then we'll bring a patient back in a week or two to put the wire down the neck and the battery in the chest. So they stage the procedure. I do it all in one surgery because the patient is already asleep, and it's just, I think it's more convenient for the patient. And so that adds another probably hour onto the surgery itself. But for convenience purposes, and I think too, I like to avoid having to do a second surgery on somebody, reduce infection, things like that. So if I can just get it all done in one surgery, I will. And so that will make the surgery a little bit longer. So I think most patients, like the idea of having the whole thing put in one setting and not having to come back as well. So I think, I want this experience to be as pleasant for the patient as possible. And I think that's my goal as a surgeon who can do the surgery either well, in my opinion. What makes me choose to do the asleep? It's really just out of convenience for the patient. I think we can do both safely, and I think the technology for a sleep surgery is so good that we can. I feel comfortable doing it without having the patient awake. And so, I think it's easier for the patient at the end of the day.
Anybody else have any other questions?
Well, I do. Do you turn the stimulation on immediately, or do you wait for the patient to get used to the surgery results first and then turn it on a week later or 2 weeks later or 3 weeks later? Because I've heard sometimes that doesn't get turned on immediately.
Yeah, that's a very good question. Typically what I'll do is I wait a couple weeks before turning it on or doing the programming, for a couple of reasons. One, I want the patient to just heal up from the surgery. So typically 2 weeks, incisions are healed and the dust is kind of settled on the fact that you had brain surgery. So that there's that. And then two, there's something called a micro lesion effect that can happen after you put deep brain stimulation leads on. And it's sort of an interesting phenomenon. It's where a patient may experience improvement in their symptoms just by having the lead introduced into the brain and not having it even turned on. And we think that's because just the mechanical process of putting it into brain tissue sort of stuns those cells that are firing, inappropriately, causing the symptoms of Parkinson's disease to then sort of behave. And so I'll have some patients that tell me when they follow up, I'm so much better and you haven't even turned me on. And so one of the reasons why we don't program right away is we don't want our programming to be confounded by any possible micro lesion effect. So micro lesion effect's usually gone after a couple weeks. And so, we want to start programming a patient when they're, having their symptoms, and when we can actually, and they can actually tell, hey, I do feel a difference. So I think waiting allows for that. I think it's important to note, if a patient doesn't get a microlesion effect, it's not a bad thing, or it doesn't mean that they're not going to have a benefit from stimulation. I've had some patients tell me, who have done their research and read up on this, after surgery, oh, I didn't have a microlesion effect, I'm not going to get benefit when it's turned on. And that's simply not the case. We don't know why some folks have it and some don't, but the presence of it is good. It typically means you're in the right spot and patient will respond good to stimulation, but the lack of it doesn't mean anything. Doesn't mean you're not going to have a good response to stimulation.
Have you ever done a case where you've extracted older technology leads and replaced them with newer technology leads?
So it's a really good question. Not necessarily for not solely on the grounds of putting in a newer lead. I'll do it in instances where maybe the patient had their surgery somewhere else, or in an instance maybe where a patient didn't get a good response to stimulation. And in those instances, what I do is I look at their, CAT scan or their MRI, and I look at where their leads are located. And if their leads aren't in the appropriate location, then I will take them back and put new ones in and take the old ones out. If the leads are located within a good location, I typically won't remove them and put in the newer leads. I don't think we have much evidence that those newer leads in a patient that's not getting a good enough response will suddenly give them the response they're looking for. I think when you weigh the risks and benefits of putting someone under surgery, I think that, in my opinion, it just wouldn't be worth subjecting a patient to the risks of surgery solely to swap out the directional lead with the old lead. What I have done, or what I've seen, is that sometimes the patient might have old leads in the brain, but they get a new battery put in their chest, and it might be a battery from a different company. And the reason why that is done is because some of these companies have what's called multiple independent current. And so what that allows for is it allows for the degree of stimulation to be changed at each specific lead with a different current. And so that can offer potentially more stimulation options to a patient that could potentially give them some efficacy. The reason why we're more willing to do that is because we're talking about just swapping out and opening up the chest and just swapping out the battery, as opposed to having to poke the brain again with leads. And so I think I'm certainly more amenable to trying that, as opposed to just putting someone through another brain surgery when their leads are accurate, when we've determined that the leads in the brain are accurate. But like I said, if they're not accurate, I will take somebody back and put new ones in using this technology, which is very good at getting it to the precise location with good accuracy, then I will do that.
I have a question. The sleep surgery, does it matter which product you use, whether it's the Medtronic or Boston or whatever the third one is?
It's a good question. It does not. It's not a straightforward answer, though, because if we're putting bilateral brain leads in, so we're doing both sides at the same time, and this is also, this is something that, like, as I mentioned, there's a lot of subtleties to the way these surgeries are done, or the plan of how the surgery is done. Some folks I see in clinic might have such significant symptoms only on one side, right? So maybe only their right side is affected. Typically Parkinson's affects one side of the body more, at least initially, and then eventually the other side will come later. So if I see somebody who has pretty significant symptoms only on one side of their body, then I will implant only one side of the brain, the side of the brain that's causing the symptoms. And the patient will only have one side done. doing this procedure, if I were to take a patient back, because what I'll do then sometimes is if a patient then starts to develop symptoms on the other side, say a year or 2 years later, then I'll take them back and do the other side. Well, some manufacturers don't allow for MRI to be done with the system in, or at least the MRI that I use. So I use a stronger MRI. It's called a 3 Tesla. And so some manufacturers don't allow for 3 Tesla MRI, at least not yet. Hopefully we'll get labeling for it eventually. But that would be the only instance where that would be an issue. And if we are going to do only one side in a patient and we think that we might do the other side later on, that's just something that I'm going to be aware of. And I'll talk to the patient about that beforehand and say, look, I think since there's a chance you might need to come back and get the other side, let's implant this system. So I think, as I kind of mentioned at the beginning of the talk, I'm not tied to any specific manufacturer, and I think each one is good depending on the situation that the patient's in. And so that's what's nice about having 3 options, is that we can talk about all 3, the pluses and minuses, and then see which one fits that specific patient's needs the most. And so I think that's the important thing.
Thank you.
Crickets.
Anybody else?
All right. Well, I really appreciate all the questions, and thanks again for having me. And hopefully in the near future, we'll be able to meet in person, and I'm happy to come out again and give a talk on another topic. Like I said, we could talk for hours about different aspects of Parkinson's disease and deep brain stimulation. So thank you very much. Appreciate it.
Thank you.
Thank
Yes.
you.
Thank you so much for your time on a Saturday, and for the rest of you that live in the area. Just a announcement for CAPS. We have a breakfast. Our next breakfast social at Taco Deli on Burnett Road is going to be Thursday, April 21st at 9 a.m. So if you are around and would like some free breakfast, we'd love to get to mingle with you and build community. And then Victor, do you have any other announcements?
No, Sarah, I think you've covered it all quite nicely. Thank you.
All right. Well, thank you guys so much for attending, and we hope you all have a great rest of your weekend.
Thank you.
Thank you for doing all this.
Of course. See you next time.
Bye-bye.
Bye.